Walk. Simulation 11. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. What is the underlying defect? A 2-year-old child of Mediterranean descent presents with severe anemia requiring regular transfusions since infancy. Exam: pallor, frontal bossing with chipmunk facies, and hepatosplenomegaly. X-ray of the skull shows a crew-cut appearance. Smear shows target cells and nucleated red cells. Hemoglobin electrophoresis shows markedly increased HbF and absent hemoglobin. Read the command. Underlying defect: transfusion-dependent anemia from infancy, chipmunk facies, crew-cut skull, target cells, high HbF, absent HbA. Beta thalassemia major. Beta thalassemia major results from mutations, usually point mutations affecting splicing or promoters that abolish beta globin chain synthesis. With no beta chains, normal adult hemoglobin HbA alpha 2 beta 2 cannot form. The excess unpaired alpha chains precipitate, damaging red cell precursors and causing severe ineffective erythropoiesis and causing severe ineffective erythropoiesis and hemolysis. The body compensates by massively expanding the marrow, which causes the frontal bossing, chipmunk facies, and crew-cut skull, and by producing more HbF alpha 2 gamma 2, which is markedly elevated. The correct answer is C. The marrow expansion and chronic transfusions both drive iron overload, so these patients need iron chelation. Distinguish the thalassemias. Beta thalassemia chromosome 11. Point mutations affecting chain production versus alpha thalassemia chromosome 16, usually gene deletions. Absent HbA with high HbF and the skeletal changes points to beta thalassemia major. What is the diagnosis and where is the conduction block? A 70-year-old man has an ECG that shows progressive lengthening of the PR interval from beat to beat until a QRS complex is dropped, after which the cycle resets. He is asymptomatic. Read the command, diagnosis and location of block. Progressive PR lengthening until a drop beat. Mobitz. I. Wenckebach at the AV node. This is Mobitz type I second degree AV block. Wenckebach. The hallmark is progressive prolongation of the PR interval beat after beat until one P wave fails to conduct and a QRS is dropped, then the cycle resets. The block is located at the AV node itself, where conduction progressively fatigues. Mobitz I is usually benign, often related to high vagal tone or AV nodal blocking drugs, and typically does not require a pacemaker in an asymptomatic patient. The correct answer is D. The critical contrast is Mobitz type 2, choice B. There, the PR interval is constant, and then a beat is suddenly dropped without warning. Mobitz II is I infranodal in the His-Purkinje system, is more dangerous because it can progress abruptly to complete heart block and usually requires a pacemaker. So, progressive PR lengthening equals Mobitz I benign, AV node, constant PR with sudden drop equals Mobitz II, dangerous, His-Purkinje. What is the underlying problem and the role of the deficient vitamin? A 14-month-old exclusively breastfed infant who lives at a high latitude with little sun exposure presents with delayed motor milestones, bowing of the legs, a rachitic rosary at the costochondral junctions, and widened wrists. Labs: low calcium, low phosphate, elevated alkaline phosphatase, elevated PTH, low 25 hydroxyvitamin D. Read the command, underlying problem and role of vitamin. Breastfed infant, low sun, bowed legs, rachitic rosary, low calcium phosphate, low vitamin D, rickets from vitamin D deficiency. Vitamin D deficiency in children causes rickets. Vitamin D, activated by the skin with sunlight, then hydroxylated in the liver and kidney to calcitriol, is essential for absorbing calcium and phosphate from the gut. Without it, the body cannot absorb enough calcium and phosphate to mineralize groin bone, so the osteoid laid down remains soft and unmineralized. In children with open growth plates, this produces the classic skeletal deformities, bowed legs, the rachitic rosary at the costochondral junctions, widened wrists, and frontal bossing. Low vitamin D leads to low calcium, which drives up PTH, secondary hyperparathyroidism, wasting phosphate. Correct answer is A. The same deficiency in adults after growth plates close causes osteomalacia, soft bones, pseudofractures, and bone pain without the growth plate deformities. Breastfed infants are at risk because breast milk is low in vitamin D, which is why supplementation is recommended. Low vitamin D, impairing calcium and phosphate absorption and bone mineralization, is the mechanism of rickets. Occlusion of which artery explains this lateral medullary syndrome? A 64-year-old man has sudden onset of vertigo, vomiting, and difficulty swallowing. Exam, loss of pain and temperature on the left face and the right body, hoarseness, and absent gag reflex, ipsilateral Horner syndrome, and ipsilateral limb ataxia. There is no limb weakness. Read the command, which artery, vertigo, dysphagia, cross-sensory loss, face one side, body other, hoarseness, Horner, ataxia, no weakness, lateral, medullary, Wallenberg syndrome, pica. This is the lateral medullary syndrome. Wallenberg syndrome, from occlusion of the posterior inferior cerebellar artery, pica. The lateral medulla packs in multiple structures. The spinal trigeminal nucleus gives ipsilateral left facial pain and temperature loss, while the already crossed spinothalamic tract gives contralateral right body pain and temperature loss. The crossed sensory pattern. The nucleus ambiguous gives dysphagia, hoarseness, and absent gag. Descending sympathetic fibers give ipsilateral Horner syndrome. The inferior cerebellar peduncle and vestibular nuclei give ataxia and vertigo. The correct answer is D. The defining clue is the combination of cross-sensory loss, bulbar findings, dysphagia, hoarseness from nucleus ambiguous, Horner, and ataxia, without limb weakness, because the lateral medulla spares the corticospinal tract, which runs medially. Don't pick a horse pichia that can't eat dysphagia. Pichia occlusion produces the lateral medullary Wallenberg syndrome. What is the underlying pathophysiology? A 45-year-old obese woman presents with several hours of severe right upper quadrant pain radiating to the right shoulder, nausea, and fever after a fatty meal. On exam, palpation of the RUQ during inspiration causes her to hold her breath in pain. Positive Murphy sign. Ultrasound shows gallstones, a thickened gallbladder wall, and pericholecystic fluid. Read the command. Underlying pathophysiology. Fatty food trigger, RUQ pain to shoulder, fever, positive Murphy sign, gallstones with wall thickening, acute calculus cholecystitis from cystic duct obstruction. Acute cholecystitis is caused by a gallstone impacted in the cystic DUT. When the stone blocks the cystic duct, the gallbladder cannot empty. Bile is trapped and concentrated. The wall becomes inflamed and edematous, and secondary bacterial infection often follows. This produces persistent RUQ pain in contrast to the transient pain of simple biliary colic. Pain referred to the right shoulder via diaphragmatic irritation, fever, and the positive Murphy sign. Inspiratory arrest when the inflamed gallbladder descends onto the examining hand. Ultrasound shows stones, wall thickening, and pericholecystic fluid. Correct answer is A. The risk factors are the 4 F's. Female, 40, fat, fertile, reflecting cholesterol stone formation. Distinguish the sites. A cystic duct stone causes cholecystitis, this case. A common bile duct stone, choledocholithiasis, causes obstructed jaundice and can cause ascending cholangitis or gallstone pancreatitis. The cystic duct obstruction with a positive Murphy sign is acute cholecystitis. What is the underlying physiologic problem? A 22-year-old man is stabbed in the chest. He becomes acutely short of breath. On the affected side, hyperresonance to percussion, absent breath sounds, and the trachea is deviated to the opposite side. Blood pressure falls. Read the command. Underlying physiologic problem. penetrating chest trauma, hyperresonance, absent breath sounds, tracheal deviation, airway, hypotension, tension pneumothorax. In a tension pneumothorax, a one-way valve injury lets air enter the pleural space during inspiration but not leave during expiration. Air progressively accumulates, and the intrapleural pressure, normally negative, becomes positive. This collapses the lung on the affected side. Absent breath sounds, hyperresonance, and, as pressure mounts, pushes the mediastinum and trachea toward the opposite side. The shifting mediastinum kinks the great veins and reduces venous return to the heart, causing the hypotension and obstructive shock. The correct answer is B. The key distinguishing sign of a tension pneumothorax versus a simple one is the tracheal deviation, away from the affected side plus hemodynamic collapse. That combination signals the mediastinal shift compressing the heart and great vessels. This is a clinical diagnosis requiring immediate needle decompression in the second intercostal space, then a chest tube. Do not wait for imaging. Trapped air raising intrapleural pressure is the physiologic core. What is the mechanism of aspirin's antiplatelet effect? A 58-year-old man is started on low-dose aspirin after a transient ischemic attack for secondary stroke prevention. Read the command, mechanism of aspirin's antiplatelet effect. Aspirin, irreversible, COX inhibition reducing thromboxane A2 for the platelet's lifetime. Aspirin irreversibly inhibits cyclooxygenase by acetylating it. In platelets, COX-1 is needed to produce thromboxane A2, a potent promoter of platelet aggregation and vasoconstriction. By irreversibly blocking COX, aspirin reduces thromboxane A2 production. Critically, platelets have NO nucleus, so they cannot synthesize new COX enzyme. The inhibition lasts for the entire lifespan of the platelet, about 7 to 10 days. This is why aspirin's antiplatelet effect is prolonged and why it must be stopped about a week before surgery. The correct answer is C. The irreversibility plus the platelet's lack of a nucleus is the key concept that separates aspirin from other NSAIDs which inhibit COX reversibly. Match the antiplatelet classes. Aspirin blocks thromboxane via COX, clopidogrel blocks the ADP-P2Y2 receptor, and abciximab blocks the GPI-IB receptor. Irreversible COX inhibition, reducing thromboxane A2 for the platelet's lifespan, is aspirin's mechanism. What is the most likely diagnosis, and what do the inclusions represent? A 60-year-old man presents with fatigue, easy bruising, and recurrent infections. CBC, pancytopenia with circulating blasts. Bone marrow shows 20% myoblasts. The blasts contain pink, rod-shaped cytoplasmic inclusions and are positive for myeloperoxidase. Read the command, diagnosis, and what the inclusions represent. Adult, pancytopenia with blasts, more than 20% myoblasts, myeloperoxidase, positive with rod-shaped inclusions. Acute myeloid leukemia with hour rods. This is acute myeloid leukemia. AML is defined by 20% or more myeloblasts in the marrow, and it is the most common acute leukemia in adults. The blasts are of myeloid lineage, confirmed by positive myeloperoxidase staining. The pink, rod-shaped cytoplasmic inclusions are AUER rods, crystallized aggregates of myeloperoxidase, containing granules. Our rods are essentially pathognomonic for AML and are not seen in lymphoblastic leukemia. The marrow replacement causes the pancytopenia, with bleeding, infections, and fatigue. The correct answer is C. Contrast with ALL, lymphoblasts are TDT positive and myeloperoxidase negative, and they lack hour rods, and ALL is more common in children. The presence of hour rods and myeloperoxidase positivity firmly places this in the myeloid lineage. The acute promyelocytic subtype APL-215-17 shows abundant hour rods, sometimes in bundles, and carries DIC risk. Myeloperoxidase positive blasts with hour rods equals AML. What is the mechanism of this food poisoning? 6 people developed nausea, vomiting, and abdominal cramps about 3 hours after eating potato salad and custard at a picnic. The illness resolves within 12 hours. The food was left unrefrigerated. The implicated organism is a gram-positive coccus in clusters that is catalase positive and coagulase positive. Read the command. Mechanism of food poisoning. Rapid onset hours. Vomiting after unrefrigerated food. Coagulase positive gram. Positive cocci in clusters. Staph aureus preformed enterotoxin. Staphylococcus aureus food poisoning is caused by ingestion of a P-format, heat-stable enterotoxin INT to the food, not by infection with live bacteria. The organism grows in improperly stored food, especially protein, and starch-rich foods like custard, potato salad, and mayonnaise left at room temperature, and secretes its enterotoxin INT to the food. When eaten, the preformed toxin acts rapidly as a superantigen on the gut, causing intense nausea and vomiting within 1 to 6 hours. Because the toxin is already made and heat-stable, reheating the food does not prevent illness, and the rapid onset reflects that no incubation or colonization is needed. The correct answer is A. The rapid onset hours, not days, is the key clue that the toxin is P-formed, distinguishing it from organisms that must first colonize and then produce toxin over a longer incubation. The illness is brief and self-limited. Bacillus cereus, classically from reheated fried rice, causes an identical rapid onset vomiting syndrome by the same preformed toxin mechanism. Coagulase positive clusters with rapid vomiting after unrefrigerated food is Staph aureus preformed enterotoxin. Which process is the primary source of blood glucose at this stage of fasting, and in which organ? A healthy person fasts for 18 hours. To maintain blood glucose, the body shifts metabolism. The physiologist notes rising glucagon and falling insulin. Read the command, primary source of blood glucose and the organ. 18-hour fast, high glucagon. Hepatic glycogenolysis transitioning to hepatic gluconeogenesis. During fasting, glucagon rises and insulin falls, signaling the liver to maintain blood glucose. The timeline matters. In the first several hours, the main source is hepatic glycogenolysis. The liver breaks down its glycogen stores to release glucose, but hepatic glycogen is largely depleted by roughly 12 to 24 hours. So by 18 hours of fasting, the body is transitioning to hepatic glyconeogenesis, synthesizing new glucose from lactate, glycerol, and amino acids. The liver is the key organ for both because it has glucose, 6-phosphatase to release free glucose into the blood. The correct answer is E. The key reason muscle cannot contribute glucose to the blood choice, B, is that muscle LAC cakes glucose, 6-phosphatase. So muscle glycogen can only be used locally, not exported. Only the liver and kidney can release free glucose. With prolonged starvation beyond a day or two, the brain shifts to using ketone bodies to spare glucose. At 18 hours, the liver carries the load via glycogenolysis, transitioning to gluconeogenesis. What is the composition of these crystals and the underlying metabolic abnormality? A 55-year-old man with obesity and heavy alcohol use presents with sudden, excruciating pain, redness, and swelling of the right first metatarsophalangeal joint, the big toe. Arthrocentesis shows needle-shaped crystals that are negatively birefringent, yellow when parallel to the polarizer. Read the command, crystal composition, and metabolic abnormality. Podagra, big toe, needle-shaped, negatively birefringent crystals. Gout, monosodium urate from hyperuricemia. This is gout. The crystals are monosodium urate, which precipitate when serum uric acid is chronically elevated. Hyperuricemia. They are needle-shaped and negatively birefringent under polarized light, yellow when aligned parallel to the polarizer, blue when perpendicular. Gout classically strikes the first metatarsophalangeal joint, podagra, with sudden severe pain, redness, and swelling, often triggered by alcohol, a purine-rich meal, or dehydration. Hyperuricemia arises from either underexcretion, most common, or overproduction of uric acid. The correct answer is D. The crucial contrast is with pseudogout, choice E, calcium pyrophosphate crystals, which are rhomboid-shaped and positively birefringent blue when parallel, often in the knee. Remember, gout, needles, negative, pseudogout, positive, rhomboid. Acute gout is treated with NSAIDs, colchicine, or steroids. Chronic management lowers urate with allopurinol. Needles shake negatively birefringent monosodium urate crystals from hyperuricemia, defying gout. A herniated disc compressing which nerve root best explains this. A 38-year-old man develops acute low back pain after lifting a heavy box, with pain radiating down the back of the left leg to the foot. Exam. Weakness of plantar flexion, difficulty standing on toes, a diminished ankle, Achilles reflex, and sensory loss over the posterolateral leg and lateral foot. A positive straight leg raise reproduces the pain. Read the command, which nerve root? Sciatica, weak plantar flexion, lost ankle reflex, lateral foot sensory loss, S1 radiculopathy. This is an S1 radiculopathy, typically from an L5-S1 disc herniation. Each lumbosacral root has a signature. The S1 root supplies plantar flexion gastrocnemius and soleus, so compression causes weakness standing on the toes. It carries the Achilles ankle reflex, which is diminished, and it provides sensation to the posterolateral leg and the lateral foot and sole. The positive straight leg raise indicates nerve root tension. All three findings, plantar flexion weakness, lost ankle reflex, lateral foot sensory loss, localized to S1. The correct answer is C. Contrast with the L5 root, choice B. L5 compression causes weak dorsiflexion and big toe extension, foot drop, and sensory loss over the dorsum of the foot and the great toe, with a normal ankle reflex. So L5 affects dorsiflexion and the dorsomedial foot, while S1 affects plantar flexion, the ankle reflex, and the lateral foot. The plantar flexion weakness with the lost ankle reflex pins this to the S1 root. What type of study is this, and which measure of association can it directly calculate? Investigators enroll 5,000 healthy non-smokers and 5,000 healthy smokers and follow them forward for 20 years, recording who develops lung cancer in each group. Read the command, study type, and measure. Enroll by exposure, smokers versus non-smokers. Follow forward for outcome. Prospective cohort calculates relative risk and incidence. This is a prospective cohort study. The defining feature is that participants are grouped by their e-exposure status, smokers versus non-smokers, and then followed forward in time to see who develops the outcome, lung cancer. Because you track new cases over time in each group, you can directly measure incidence and calculate the relative risk, the ratio of the incidence in the exposed to the incidence in the unexposed. Cohort studies move from exposure to outcome in the natural direction of time. The correct answer is E. Distinguish the designs. A cohort study selects by exposure and looks forward, yielding relative risk. A CA case control study selects by disease cases versus controls and looks backward at exposure, yielding only an odds ratio because incidence cannot be measured. A cross-sectional study is a snapshot, yielding prevalence. Following exposure groups forward to measure incidence is the hallmark of a cohort study, which gives relative risk. A deficiency of which enzyme causes this condition? A 40-year-old man notices that his urine turns black when left standing. He also has dark pigmentation of the sclera and ear cartilage and has developed early severe arthritis of the spine. Lab analysis shows accumulation of homogentic acid. Read the command. Which enzyme? Urine blackens on standing. Ochronosis. Dark sclera cartilage. Arthritis. Homogentic acid accumulation. Alkaptonuria, homogentisate oxidase deficiency. Alkaptonuria is caused by a deficiency of homogentisate oxidase, an enzyme in the degradation pathway of the amino acid tyrosine. Without it, homogentic acid cannot be broken down and accumulates. When excreted in the urine and exposed to air, homogentic acid oxidizes and polymerizes into a dark pigment, turning the urine BLACK on standing. The pigment also deposits in connected tissue, cartilage, sclera, and skin, a bluish-black discoloration called ochronosis, and it damages joints, causing a destructive arthritis, especially of the spine. The correct answer is B. Alkaptonuria is an autosomal recessive disorder of tyrosine metabolism and is relatively benign apart from the arthritis. Keep the tyrosine pathway diseases straight. Phenylalanine hydroxylase deficiency causes PKU, tyrosinase deficiency causes albinism, and homogentisate oxidase deficiency causes alkaptonuria. The triad of black urine on standing, ochronosis, and arthritis with homogentisic acid accumulation points to homogentisate oxidase deficiency. Which genetic mutation underlies this syndrome? A 35-year-old man presents with a neck mass and episodic flushing and diarrhea. He has a strong family history of thyroid cancer. Exam shows multiple mucosal neuromas on the lips and tongue and a morphinoid body habitus. Labs, elevated calcitonin and elevated plasma metanephrines. Biopsy of the thyroid shows malignant C cells with amyloid stroma. Read the command. Which mutation? Medullary thyroid carcinoma, calcitonin, C cells, amyloid, pheochromocytoma, metanephrines, mucosal neuromas, morphinoid, meant to be red mutation. This is multiple endocrine neoplasia type 2b, caused by a germline mutation in the RET proto-oncogene. MEN2B features the combination of medullary thyroid carcinoma, a malignancy of the calcitonin-secreting C cells, with characteristic amyloid stroma, pheochromocytoma, the elevated metanephrines, mucosal neuromas on the lips and tongue, and a morphinoid body habitus. Both MEN2A and MEN2B are red-driven. Because medullary thyroid carcinoma is essentially universal and aggressive in red carriers, prophylactic thyroidectomy is recommended. Correct answer is A. No. The MEN syndromes. MEN1, the MEN yin gene, is the 3 Ps: pituitary, parathyroid, pancreas. MEN2A ret is medullary thyroid carcinoma, pheochromocytoma, and parathyroid hyperplasia. MEN2B ret is medullary thyroid carcinoma, pheochromocytoma, and mucosal neuromas with morphinoid habitus, but no parathyroid disease. The mucosal neuromas and morphinoid habitus distinguish 2B, and RET is the gene for all MEN2. What is the most likely underlying cardiac lesion, and what causes the fixed splitting? On cardiac auscultation of a 25-year-old woman, the second heart sound WS2 shows a wide fixed split that does not vary with respiration. She is otherwise asymptomatic, with a soft systolic murmur at the left upper sternal border. Read the command, lesion, and cause of fixed splitting. Wide fixed split S2, not varying with respiration, atrial septal defect. A wide, fixed splitting of S2, meaning the gap between aortic A2 and pulmonic P2 closure stays constant through the respiratory cycle, is the classic sign of an atrial septal defect. Normally, the split widens with ion aspiration because increased venous return delays pulmonic closure, then narrows with expiration. In MASD, the left-to-right shunt across the defect lets the two atria equalize their filling. Because the right heart volume is now buffered by the defect, respiration no longer changes the relative filling, so the split is fixed ed. It does not vary with breathing. The correct answer is B. The chronic left-to-right shunt also increases pulmonary flow, producing the soft systolic flow murmur at the pulmonic area. The key auscultatory pearl is that normal physiologic splitting varies with respiration, wider on inspiration, whereas a fixed ED split that ignores respiration signals in ASD. A wide fixed split S2 is the buzzword for atrial septal defect. What is the underlying immunologic mechanism? A 32-year-old woman presents with weight loss, heat intolerance, palpitations, tremor, and anxiety. Exam, tachycardia, a diffusely enlarged non-tender goiter with a bruit, exophthalmos, proptosis, and raised, non-pitting plaques on the shins, pretibial myxedema. Labs, suppressed TSH, elevated free T4. Read the command, underlying immunologic mechanism. Hyperthyroidism with diffuse goiter, exophthalmos, pretibial myxedema, suppressed TSH, Graves' disease, TSH receptor, stimulating antibodies. Graves' disease is the most common cause of hyperthyroidism, and the mechanism is autoimmune. Patients produce IgG autoantibodies, thyroid-stimulating immunoglobulins, that bind and ACTA, the TSH receptor on thyroid follicular cells. This drives continuous unregulated production of thyroid hormone independent of pituitary control, so free T4 is high and TSH is suppressed by feedback. This is a type 2 hypersensitivity reaction, but unusual in that the antibody stimulates rather than destroys. The result is the diffuse goiter and the hyperthyroid symptoms. The correct answer is B. Two findings are specific to Graves and not seen in other causes of hypothyroidism. Exophthalmos from glycosaminoglycan deposition and inflammation behind the eyes, and pertibial myxedema, both driven by the antibodies and associated immune activity. Contrast with Hashimoto thyroiditis, where antibodies destroy the gland causing hypothyroidism. The stimulating TSH receptor antibody is the Graves mechanism. Treat with antithyroid drugs, radioiodine, or surgery. What is the mechanism of the cardiotoxicity and the antidote for it? A 19-year-old woman is brought to the ED after an intentional overdose. She is confused with dilated pupils, dry flushed skin, urinary retention, and tachycardia. ECG shows a widening QRS complex and a prolonged QT. She has a seizure. The ingested drug is used for depression. Read the command, mechanism of cardiotoxicity and antidote. Tricyclic antidepressant overdose, anticholinergic signs, wide QRS from sodium channel blockade, treated with sodium bicarbonate. This is a tricyclic antidepressant overdose. TCAs have multiple receptor effects. They are anticholinergic, the dilated pupils, dry flushed skin, urinary retention, and tachycardia. The 3 C's plus anticholinergic, they lower the seizure threshold, and most dangerously, they block cardiac fast SO-ion channels. Sodium channel blockade slows phase 0 depolarization in the myocardium, widening the QRS complex and predisposing to ventricular arrhythmias, the leading cause of death in TCA overdose. The antidote for the cardiotoxicity is sodium bicarbonate. The correct answer is E. Sodium bicarbonate works 2 ways. It raises serum sodium, increasing the gradient to overcome the channel blockade, and it alkalinizes the blood, which reduces the drug's binding to the sodium channel. A widening QRS is the key indicator to give bicarbonate and predict seizures and arrhythmias. The 3 C's of TCA toxicity: convulsions, coma, cardiotoxicity, plus a wide QRS responding to sodium bicarbonate is the classic picture. What is the route of spread of this virus to the CNS? A 30-year-old man presents with anxiety, difficulty swallowing, and painful throat spasms when attempting to drink water, hydrophobia. He recalls a bat in his bedroom 6 weeks ago. He develops agitation, hypersalivation, and fluctuating consciousness. Histology of brain tissue later shows eosinophilic cytoplasmic inclusions in hippocampal neurons. Read the command. Route of spread to the CNS: hydrophobia, hypersalivation, bat exposure, eosinophilic neuronal inclusions, Negri bodies, rabies. Spreading by retrograde axonal transport. Rabies virus spreads to the central nervous system by retrograde transport along peripheral nerves. After a bite inoculates the virus into muscle, it binds acetylcholine receptors at the neuromuscular junction, enters peripheral nerves, and travels retrograde, backward along the axons, up to the spinal cord and brain. This is why the incubation period varies with the distance of the bite from the brain, often weeks to months. Once in the CNS, it causes encephalitis, then spreads centrifugally to the salivary glands. The pathologic hallmark is the Negri body, an eosinophilic cytoplasmic inclusion in neurons, classically in the hippocampus and cerebellum. Correct answer is D. The clinical picture is classic: hydrophobia from painful pharyngeal spasms, hypersalivation, agitation, and fluctuating consciousness. Bats are a major reservoir, and exposure may be unrecognized because the virus travels slowly up the nerves. Post-exposure prophylaxis with vaccine and immunoglobulin can prevent disease if given before symptoms appear. Once symptoms begin, rabies is almost universally fatal. Retrograde axonal transport is the route of CNS spread. What is the underlying immunodeficiency, and why did he react to the transfusion? A 25-year-old man with a history of recurrent sinopulmonary and GI infections, especially Giardia, is given a blood transfusion and develops a severe anaphylactic reaction. Workup shows a very low serum IgA with normal IgG and IgM. Read the command, the immunodeficiency, and the transfusion reaction. Recurrent mucosal infections, Giardia, anaphylaxis to transfusion, isolated low IgA, selective IgA deficiency. Selective IgA deficiency is the most common primary immunodeficiency. IgA is the main antibody of mucosal surfaces, so patients have recurrent sinopulmonary and gastrointestinal infections. Giardia is a classic offender, though many are asymptomatic. The other immunoglobulin classes, IgG and IgM, are normal, which distinguishes it from the panhypogammaglobulinemias. The dangerous feature highlighted here is the transfusion reaction. Because these patients lack IgA, some form anti-IgA antibodies, and when exposed to IgA in donated blood products, they can mount a severe anaphylactic reaction. The correct answer is E. The isolated low IgA with normal IgG and IgM is the key lab finding, separating it from X-linked agammaglobulinemia, all immunoglobulins absent, and common variable immunodeficiency, multiple classes low. These patients should receive IgA deficient or washed blood products to avoid anaphylaxis. Selective IgA deficiency is also associated with celiac disease and atopy. Mucosal infections plus transfusion anaphylaxis with isolated low IgA is the picture. Block 11 is done. Let's review the 5 biggest traps from this block. Trap 1, the second degree AB blocks. Mobitz, I has progressive PR lengthening before a drop beat and is benign. Mobitz II has a constant PR with a sudden drop beat, is infranodal, and needs a pacemaker. Trap 2, crystal arthropathies. Gout has needle-shaped, negatively birefringent monosodium urate crystals. Pseudo-gout has rhomboid, positively birefringent calcium pyrophosphate crystals. Needles negative, rhomboid positive. Trap 3, a wide fixed split of S2 that does not change with breathing is the signature of an atrial septal defect. Normal physiologic splitting widens with inspiration. Fixed means ASD. Trap 4, Graves' disease is driven by antibodies that stimulate the TSH receptor, causing hyperthyroidism with exophthalmos and pretibial myxedema. Contrast with Hashimoto, where antibodies destroy the gland and cause hypothyroidism. Trap 5, tricyclic antidepressant overdose causes anticholinergic effects, seizures, and a widened QRS from cardiac sodium channel blockade. The antidote for the cardiotoxicity is sodium bicarbonate. Train process, not memorization. 11 blocks down. Your speed and accuracy keep climbing. StepLogic, learn how to think, not memorize.